Am I audible now? So shall we start now? Okay. So next topic we will discuss retina. So in retina we have already discussed fundus examination, right? How you visualize the retina with the fundus examination, which instruments are used to visualize the fundus. So there are two instruments, direct ophthalmoscope and indirect ophthalmoscope. This one is direct ophthalmoscope and this is your indirect ophthalmoscope. Okay. So what is the basic difference between direct ophthalmoscope and indirect ophthalmoscope? Through the help of these two instruments, we use them in OPD to visualize the fundus and retina examination is done. So this, I want to tell you, direct ophthalmoscope is nowadays it is obsolete. We don't use it very frequently. Which is used is indirect ophthalmoscope. Why? What are the advantages of indirect ophthalmoscopy over the direct ophthalmoscopy? These we will discuss in detail now. So write down next topic in retina. We will discuss investigations. Write down the heading, investigations of retina. So first is ophthalmoscopy. So there are two types of ophthalmoscopy, direct ophthalmoscopy and indirect ophthalmoscopy. Talking about magnification of image, when you visualize the retina scope, the magnification which we get in direct is 15 times magnified image is seen, whereas in indirect you get 3 to 5 times magnified image. In direct ophthalmoscopy, condensing lens is required. No lens is required, whereas in indirect ophthalmoscopy, a plus 20 diopter is required. Indirect ophthalmoscope, we are wearing, this is a head mounted instrument which we wear on your head, and there is a lens which is 20 diopter lens. Through that lens, we visualize the fundus of the patient. By this indirect ophthalmoscopy. Whereas in direct ophthalmoscopy, we use this direct ophthalmoscope directly to visualize through the hole in this direct, and there is no need of any condensing lens in direct ophthalmoscope. Okay. So lens is not required in direct. Talking about image, what type of image we get in direct ophthalmoscopy? It is virtual and erect. Virtual and erect, important question. Whereas it is real and inverted. Real and inverted in indirect ophthalmoscopy. Talking about the area visualized through direct ophthalmoscopy. So you can only see central fundus. Central fundus can be only seen. That means optidis plus macula. Optidis plus macula can only be seen through direct ophthalmoscopy. Can you tell me what was the diameter of macula lutea? What was the diameter of macula lutea? Message me in the chat box. What was the diameter of macula lutea? 5.5 millimeters. So only central fundus can be visualized. So this is a drawback with direct ophthalmoscope. Whereas in indirect, you can see central fundus plus you can also visualize the peripheral fundus also. You can also visualize peripheral fundus also. That means optidis can be seen plus macula plus you can see ora serrata also. So field of view indirect, whereas it is larger in indirect. Okay. Next, examination through hazy media. Examination through hazy media possible in direct ophthalmoscopy. What do you mean? There is any cataract, when there is dense cataract, or there is any cornea opacity. When there is any cornea opacity or cataract, we cannot visualize the retina with the help of direct ophthalmoscope. Whereas with indirect ophthalmoscope, it is possible to visualize fundus if the patient is having cataract or any small corneal opacity is there. So these are the advantages of indirect ophthalmoscope over the direct ophthalmoscope. Okay. Now suppose a patient is having a mature senile cataract. What was the color of mature senile cataract? It was pearly white in color. It was pearly white in color, right? So in that dense mature senile cataract, you will not be able to visualize the fundus with the help of indirect ophthalmoscopy also, right? So how you will visualize the fundus, how you can see the fundus in those cases? In those cases, we can go for next investigation, which is called as B-scan ultrasonography. OD is optic disc. OD is optic disc. Optic disc. So you can visualize optic disc plus macula plus ora serrata. Which examination? Can you explain examination? Which examination? With indirect ophthalmoscopy, suppose a patient is having intermediate uveitis. So what is the site of inflammation in intermediate uveitis? Pars plana is getting involved, right? So pars plana lies in periphery of the retina. Okay, it is just behind the second part of ciliary body. It is the periphery of the retina. Whereas central fundus means this part. This is the suppose whole fundus. This is your optic disc. These are the vessels. This is the macula lutea. Center is fovea centralis. So this part of macula and optic disc is called as central fundus. This is called as central fundus. So with the help of direct ophthalmoscope, you can only visualize central fundus. Whereas advantage of indirect is that you can visualize this peripheral part of the fundus till ora serrata with the help of indirect ophthalmoscope. With the help of direct, you can only visualize central fundus, means optic disc and macula. Okay, clear? Optic disc and macula can be visualized with direct ophthalmoscope, and periphery of the retina can be seen with indirect also. So most of the pathologies cannot be seen with the help of direct ophthalmoscope. They will not be seen. Now coming back to B-scan ultrasonography, the patients in whom they have dense cataract or dense corneal opacity is there. Very dense means mature senile cataract, pearly white color cataract is there. In those patients, you cannot visualize the fundus with the help of indirect ophthalmoscope also. So in those patients, how you will get an idea about retina? So in those cases, we can go for B-scan ultrasonography. We can go for B-scan ultrasonography. Write down B stands for brightness. B stands for brightness. So this ultrasonography, B-scan ultrasonography also have a probe. Like we have in ultrasound, we have a probe, right? So there is a probe which uses 7.5 to 10 megahertz ultrasound waves for fundus examination. In patients with opacification of ocular media. What do you mean by ocular media? Means corneal opacities, dense corneal opacities which are very big in size, or very dense cataract or mature senile cataract. So in those patients, we can do B-scan ultrasonography to examine the retina of the patient. So like this is a probe which is attached to a screen, and this probe, a jelly is applied over the eyeball, right? Jelly is applied over the eyeball, and this probe is touched over in different sectors of eyeball to get the images on the screen. MSC is mature senile cataract, pearly white in color. MSC is mature senile cataract, pearly white in color. So because it is mature, you cannot see the retina behind this cataract. Okay. So in those cases, we do B-scan ultrasonography. How the image looks like of B-scan ultrasonography. This is the picture, normal picture of B-scan ultrasonography. This shadows, you have to focus on the shadow. Can you see this shadow? This shadow is of your biconvex lens. This is your cornea. And this cavity is your vitreous cavity. Okay. This is your retina. This one. This is your retina. Can you see this shadow? This one. This is your optic nerve. So roughly you can get an idea about retina in mature senile cataract patient, dense cataract or corneal opacity patients with the help of B-scan ultrasonography. Clear or not clear? Give me a thumbs up if it is clear. Examination through hazy media means if there is opacity in the cornea, your cornea is hazy because of any opacity, or there is a dense cataract in the lens, then your media becomes hazy. You cannot see through the sun, through the light rays. So with the help of indirect ophthalmoscope also. So in those patients, we can see retina with the help of B-scan ultrasonography. Structures in the B-scan, no need to go for structures in the B-scan in detail, just get an idea that we can visualize different structures in the B-scan. This is the shadow of cornea, this is the shadow of your lens, this is center cavity, is vitreous cavity, and this is your optic nerve. So in exam, they will not ask you identify the structures in the B-scan. So that will not be the scenario in your case. You just need to remember that B-scan ultrasonography is used to see the retina in dense opacified media, dense cataract and corneal opacity. Okay? Clear or not clear? So in indirect of hazy media, suppose a cataract is there, but it is a soft cataract and it is not very dense. So in those cataracts, we can see fundus or retina through indirect ophthalmoscopy. But if the cataract is very hard, or if it is very mature, then through indirect ophthalmoscopy also we cannot see the retina. Or if there is any trauma to the patient, cornea is total white, total corneal opacity is present, then also we cannot see the fundus behind the cornea. Okay? So depends on the grading of the corneal opacity and density of the cataract. If mild one are there, we can see through indirect. If very advanced stages are there, then we have to see retina through B-scan ultrasonography. Okay, clear? Okay, so this is your B-scan ultrasonography. Next investigation is OCT. OCT is optical coherence tomography. Optical coherence tomography. So this is similar, write down, this is similar to B-scan ultrasonography, except that it uses infrared light rays instead of sound waves. Ultrasound waves. Here in OCT, we are using infrared light. Okay. So now what is OCT? This much is done. Okay, then I'll show you the picture of OCT. This is your B scan and this is your normal OCT scan. Okay, so do you remember we have discussed 9 layers of retina were there? And I told you the outermost layer was, name of the outermost layer? 9 layers, this is the outermost layer. So what was the name of that outermost layer? RPP, it's not RPP, it is RPE, right? Retinal pigment epithelium is the outermost layer. Can you see in this scan, which is the pigmented layer, which you can see? This one, right? Can you see this is pigmentation? Yeah. So this layer is called as RPE, okay? And as you go, these are the inner layers. This is the outermost layer. Beneath the RPE is your choroid. This is your choroid, right? And this center depression, can you see this central depression? This is your fovea centralis. And this is your innermost layer of retina, internal limiting membrane. Okay? And this is your vitreous humor. So now what is the use of OCT? Why are we getting another scan? Now, as I have told you, in posterior uveitis and intermediate uveitis, because the inflammation is involved in the posterior segment, so there is a term which we have discussed, that is your cystoid macular edema, right? So there is an edema in the macula and fovea centralis, okay? So on fundus examination, we see an edema at the macula. Now we want to quantify this edema. How much is the edema? So in order to quantify that edema, we go for OCT scan. Okay. Now suppose the patient has come on day 1 of posterior uveitis, and so I want to confirm how much is the edema at the macula. Suppose it is 550 micrometer thickness is there at the macula because of edema. Now I started the patient on steroids, periocular injections are given, steroids are given, systemic steroids are started. And on follow-up of the patient, I want to check whether the effect of the treatment is there or not, whether the edema is decreasing or not. So how I will check whether the edema is decreasing or not? With the help of OCT scans. So another follow-up visit, I do repeat OCT and I'll see that the edema is increasing or decreasing. So whether there is effect of the treatment or not. Okay. So in those patients, OCT is a confirmatory findings, right? So we can confirm whether that the patient is responding or not responding. Clear? Give me a thumbs up if it is clear. So I can visualize at what layer the edema is there. Out of the 10 layers, I can see through this OCT in which layer of the retina 10 layers there is edema or there is any pathology is present, I can appreciate. So this is a kind of CT scan of eye. OCT is a kind of CT scan, right? So I can see which strata of retinal layers are getting involved in the disease. Clear or not? Give me a thumbs up if it is clear. I can quantify the edema with the help of OCT. Clear? Now, suppose a patient has diabetes, uncontrolled diabetes, fasting is 250 and post PP is 500. So he is having diabetic retinopathy changes. Okay. Now, because diabetic retinopathy changes are present, there is macular edema. There is macular edema. And as you know that diabetes is a disease of capillaries. It is a capillaropathy. Diabetes is a disease of capillaries. There is leakage from the capillaries. Okay. So that is why there is hemorrhage in the retina. In diabetes, because of capilloropathy, there are certain hemorrhages in the retina. Now, suppose I want to locate the exact point of bleeding in the retina. I want to locate at what point the hemorrhages are present. So, by which technique I will locate the exact point of leakage of blood? For that, there is another investigation which is called as FFA, which is called as Fundus Fluorescein Angiography. So this is the picture of fundus fluorescein angiography. A dye is injected in the patient in the antecubital vein in the hand, right? So a fluorescein dye is injected in the antecubital vein and certain pictures are clicked from the eye with the help of a camera. And then we get these type of images. And can you see this white leakage? So with the help of this fundus fluorescein angiography, we can see what is the exact site of leakage of blood in the retina. So that later on, we can do lasers, retinal lasers at those leaking points. Okay. So this is the use of FFA. FFA is fundus fluorescein angiography. Can you see diabetic retinopathy? These exudates, hemorrhages are present. So if I want to locate at what point the blood is present and what are the leaking points, I will go for another investigation after OCT that is called as fundus fluorescein angiography. Clear or not? FFA is clear. What is the main use of FFA? If you want to quantify, if you want to see what is the exact pinpoint location of leakage from the blood vessels, I will do fundus fluorescein angiography. How the fundus fluorescein angiography is done? We inject fluorescein dye, liquid dye, in the antecubital vein, right? And then that dye goes in your blood circulation. And then with the help of a camera in the eye, we take certain pictures. And what those pictures looks like this. This black and white picture will give us exact location of leakage of the capillaries so that later on we can fire laser shots at those leaking points. Clear or not clear? So now write down OCT. After OCT, write down. Next investigation is FFA. The full form is fundus fluorescein angiography. Fundus fluorescein angiography. Angio means blood vessels. Angio means blood vessels. So with the help of fluorescein dye, we are seeing the leakage in the capillaries. Okay. So write down this FFA allows study of retinal and circulation. It allows study of retinal and choroidal circulation. Next important question, write down. It is an orange color dye. It is an orange colored water soluble dye. What are the adverse drug reactions? ADR. ADR is adverse drug reaction. What are the adverse drug reaction of this dye? So you will inform the patient before doing this that he will get yellow-orange discoloration, yellow-orange discoloration of urine. Will last for 24 to 36 hours. Important question. So before doing FFA, you will inform the patient that patient will have yellow-orange discoloration of urine for the last 24 to 36 hours. And one more thing, that the route of exit of this dye is through kidneys. What is the route of exit of this dye? It is through kidneys. That is why, important question, write down. FFA should not be done in which patients? In renal compromised patients. FFA should not be done in renal compromised patients. Okay? Because the route of exit is through kidneys. So if kidneys are damaged, it can lead to toxicity. So this is all about your investigations, OCT and FFA, B scan and ophthalmoscopy, direct ophthalmoscopy and indirect ophthalmoscopy. Now next heading, write down. Very important topic, diabetic retinopathy. Diabetic retinopathy. Write down the pathological changes. Pathological changes seen in diabetic retinopathy. If they ask you which is the earliest change in diabetic retinopathy, then answer is loss of pericytes. Important question. Pericytes. So as I told you, diabetes is a disease of small capillaries, right? So these capillaries are there, they have junctions which are called as pericytes. Pericytes are present in capillaries. So earliest change which is seen because of diabetes is loss of pericytes. Now obviously when there is loss of pericytes from the blood vessels, capillaries, what will happen in the blood vessels? There will be leakage of blood. There will be leakage. Okay, so what happens if there is leakage? Chronic leakage is there. What passes through your blood? Oxygen, right? Oxygen is passing, right? So what will happen if there is leakage? Patient will have decreased oxygen, right? What is that called as? Decreased oxygen is called as, if there is leakage from the capillaries because of loss of pericytes, so patient will have hypoxia, right? Correct. Patient will become hypoxic. Correct. Okay, so loss of pericytes will be there. Lie down. Loss of pericytes leads to leakage and occlusion of capillaries. This leads to hypoxia. Now later on, if there is prolonged hypoxia will turn into retinal tissue will become ischemic, right? Because of hypoxia, tissue will become ischemic. There will be deficiency of oxygen, right? Now, if the patient gets retinal ischemia develops, the message from the retina will go into the brain that the tissue is getting hypoxic, ischemic. What will happen? Brain will release some angiogenic factors. Brain will release some vascular angiogenic factors. Angiogenic means, angio means blood vessels, right? So brain will release some vascular angiogenic factors which will produce some new blood vessels. Okay, brain will produce some factors, vascular angiogenic factors, which will produce more blood vessels, more capillaries are newly formed, right? But the problem with these new vessels is that they are very fragile. Yes, endothelial growth factors. But the problem with these blood vessels is that they are very fragile, means they tend to bleed easily. They tend to bleed very easily. Okay, so write down, after retinal ischemia, it act as a angiogenic stimulator. Retinal ischemia act as angiogenic stimulator, and it leads to release of VEGF, vascular endothelial growth factor, and the most common one is VEGF factor A. Important question. It leads to release of VEGF, vascular endothelial growth factors. These vascular endothelial growth factor leads to neovascularization. Neovascular means new vessels. New vessels are formed. This is called as neovascularization of retina. And the problem with these new vessels is that they are very fragile and they tend to bleed easily. Okay. Now, if they ask you in question, which is the hallmark of diabetic retinopathy, answer is neovascularization of retina. Answer will be neovascularization of retina. Important question. Neovascularization of retina is the hallmark of diabetic retinopathy. Okay. This much is clear? Give me a thumbs up if it is clear. Pathogenesis. Pathogenesis is clear, diabetic retinopathy. Once again, okay. So, as I told you, that the process, the pathology starts with the loss of pericytes. Pericytes are joining the capillaries, right? So, if they are lost, then what will happen to the capillaries? There will be leakage from the capillaries, okay? When there is leakage of blood from the capillaries, what is traveling through the blood? Oxygen. So that will lead to hypoxia. Hypoxia will lead to ischemia, and ischemia will send the message to the brain, and brain will release some growth factors. The name of those growth factor is vascular endothelial growth factor. So these growth factors will produce new vessels, and this process of producing new vessels is called as neovascularization. But the problem with these new vessels is that they tend to bleed very easily because they are very fragile. Okay, so later on they will bleed more. Okay, so that neovascularization of retina is called as hallmark of diabetic retinopathy. Okay, so this is the pathogenesis of diabetic retinopathy. Clear? Right. Now next is your classification and clinical features of diabetic retinopathy. DR is diabetic retinopathy. So one classification which is commonly used and is important is named as Etdrs classification. The full form is early treatment diabetic retinopathy, early treatment diabetic retinopathy study. Okay, early treatment diabetic retinopathy study. So according to this classification, it is broadly divided into two types: diabetic retinopathy, NPDR, which is non-proliferative diabetic retinopathy, and other one is PDR, which is proliferative diabetic retinopathy. Now, as the name suggests, can you tell me, NPDR is non-proliferative diabetic retinopathy, means that the proliferation of new vessels has not started in this stage. Okay, whereas in PDR, proliferation of new vessels have already started. Now, can you tell me which is the advanced form in NPDR or PDR out of the two? Proliferation in one type, proliferation of new vessels has not begun yet, NPDR. Whereas in PDR, proliferation of new vessels have started. So, which is more advanced form, NPDR or PDR? PDR, right? So, proliferation, the stage in which PDR proliferation has already started, that is your main concern. That is your main concern in which you have to intervene and treatment should be started. Whereas in NPDR, where the proliferation of new vessels has not begun yet, in those patients, you have to continuously follow up those patients, and the patient is advised to maintain the blood sugar levels under control. Okay, rest the retina is followed up regularly. Whereas in PDR patients in which proliferation has already taken place, in those patients you need to start the treatment. Okay, now write down, in NPDR presents without proliferation of new vessels. Whereas PDR presents with proliferation of new vessels. They present with proliferation of new vessels. Okay. Now coming back to PDR, write down the management. In NPDR, you have to just follow up the patient. You need to just follow up the patient, and you require medical control of blood sugar levels. You require medical control of blood sugar levels, and you keep the patient on regular follow-up. Wherein in PDR, what you do, because of there is leakage. So if they ask you which is the treatment of choice, important question, write down. Treatment of choice in PDR, answer is pan-retinal photocoagulation. Short form is PRP. pan-retinal photocoagulation, PRP. Which laser is used for this photocoagulation? Argon laser is used. And which laser we were using in posterior capsulotomy and iridotomy? ND-YAG laser. Presents mean presents. This is present. Patient present without proliferation of new vessels. So in capsulotomy and iridotomy, we were using ND-YAG laser, whereas in retina, we are using argon laser for pan-retinal photocoagulation. Okay. Now, what is the function of laser? Why are we doing laser? If there is bleeding, any idea? Go back to the pathogenesis again. Go back to the pathogenesis. This is the pathogenesis, right? So there was earliest change was loss of pericyte, right? Then it leads to leakage. Leakage leads to hypoxia. Okay. Now, which is the main culprit in diabetic retinopathy? This one, hypoxia. This is the main culprit in diabetic retinopathy, hypoxia. Why? Because this hypoxia induces ischemia, and this ischemia induces the production of growth factors, right? So if we block hypoxia, right? If we block this hypoxia, if we make the tissue anoxic, hypoxia, right? Tissue is hypoxic. So if we make the retinal tissue anoxic, what will happen? There will be no ischemia, there will be no release of vascular endothelial growth factor, and there will be no neovascularization. There will be no new vessel formation. Okay. Now, how I will make the retinal tissue anoxic? If I burn the retinal tissue. And how I burn? With the help of laser. With the help of argon laser, I will give certain burns at the site which are leaking, and by which investigation I will see that what are the points at which there is leakage. What is the name of that investigation? Tell me in the chat box. Before doing laser, FFA. Very good. FFA is an investigation which will tell me the exact location of leakage, and how I will quantify the edema, macular edema, because of that leakage. How I will quantify in which layers of the retina the edema is present, macular edema. OCT, right. So OCT and FFA are the two investigations which are done in diabetic retinopathy. Clear? So now coming back to pan-retinal photocoagulation, argon lasers is used. Clear? Now write down summary. Summary, write down treatment of PDR. If they ask you treatment of choice, answer will be pan-retinal photocoagulation. PRP, pan-retinal photocoagulation, is the treatment of choice. It works by decreasing the oxygen demand, which in turn decreases the hypoxia, right? And which in turn decrease the VEGF release. Okay. This much is clear? This much is clear? We are decreasing VEGF. Give me a thumbs up if it is clear. Pan-retinal photocoagulation. We are making the tissue anoxic, okay, by decreasing the hypoxia, decreasing the oxygen demand, okay. Now, what if second treatment option? What if I have to decrease VEGF release, right? So either I burn the tissue and I make the tissue anoxic. Second option, what I have, if I directly inject anti-VEGF injections inside the posterior segment of your eyeball in the vitreous cavity, what will happen? Obviously, then also VEGF release will be decreased. VEGF release will be decrease. I'll send you the PDF, don't worry. After the end of the class, yesterday's PDF and today's PDF also will be forwarded to you. Okay. So what if I inject anti-VEGF injections in the posterior segment? PRP is pan-retinal photocoagulation. So in order to decrease PRP release, I can also inject anti-VEGF injections in the posterior segment cavity, in the vitreous humor. That will also decrease the neovascularization. Okay. So write down the name of anti-VEGF drugs. Anti-VEGF drugs, write down, very, very important. You have to remember the names. You cannot afford to miss the names. Ranibizumab, Ranibizumab, Ranibizumab. Second is Bevacizumab, Bevacizumab. And third is Aflibercept, Aflibercept. Very, very important. Bevacizumab, Ranibizumab, and Aflibercept. All of the three anti-VEGF drugs are important. So we can also give injections of these anti-VEGF drugs. So nowadays, as we have evolved, ophthalmology has evolved over the years. What we are doing in treatment of diabetic retinopathy, we are mixing the two entities. Okay. So suppose a patient comes to your OPD and diagnosed with diabetic retinopathy. So first of all, we do lasers, pan-retinal photocoagulation. We make the tissue anoxic, which in turn decreases the hypoxia and new vessel release is decreased. And we also inject anti-VEGF injections also, which will decrease the VEGF release. Okay. Usually 3 injections are given of anti-VEGF injections. 3 injections are given 1 month apart in a gap of 1 month. So 3 injections, and we also do pan-retinal photocoagulation in the retina. Clear? So treatment of choice, if they ask you for diabetic retinopathy, answer will not be anti-VEGF drugs. Answer will be pan-retinal photocoagulation. PRP is pan-retinal photocoagulation. So treatment of choice, if they ask you, answer will be PRP. Another treatment option is anti-VEGF drugs. Name of the 3 anti-VEGF drugs you have to remember: Ranibizumab, Bevacizumab, and Aflibercept. Give me a thumbs up if it is clear. Thumbs up if it is clear. Yes. Okay. Now next, write down what are the complications of diabetic retinopathy. So one complication, you will tell me in the chat box what is the complication of diabetic retinopathy. In the posterior segment, at the macula, what will you see? Because of leakage, neovascularization. Okay. Edema. What edema? Yes, macular edema will be there. And the name of that edema is cystoid macular edema, right? So you will see macular edema because of leakage, right? So complication, write down. Number 1 complication is diabetic macular edema. Diabetic macular edema. Short form is DME. Now write down question, important. Diabetic macular edema is most common cause of loss of vision in NPDR, non-proliferative diabetic retinopathy, and overall diabetic retinopathy. is CME is cystoid macular edema. Both are same. Diabetic macular edema is most common cause of loss of vision in NPDR and overall diabetic retinopathy. So if they ask you in question, what is the most common cause of loss of vision in diabetic retinopathy? Answer will be diabetic macular edema. Okay. If they ask you which is the most common cause of loss of vision in NPDR, then also answer will be diabetic macular edema. Okay. Diabetic macular edema. Yeah. Second, write down second complication. Second complication is vitreous hemorrhage. Vitreous hemorrhage. So there is bleeding, so much of bleeding in the vitreous hemorrhage because these new vessels have ruptured. So much of hemorrhage is there, and new vessels are seen in which type of diabetic retinopathy? New vessels are seen in NPDR or PDR. PDR is proliferative, right? So new vessels are seen in proliferation has occurred in PDR, right? So vitreous hemorrhage is seen in PDR. Write down. So what is the source of this vitreous hemorrhage? Write down. Source is neovascularization. Neovascularization of retina in PDR, proliferative diabetic retinopathy. Now write down question. This is the most, vitreous hemorrhage is the most common cause of loss of vision in PDR. In PDR. Third, write down. Third complication is retinal. Third complication is retinal detachment. Now, if they ask you question, write down. Most common cause of blindness. Most common cause of blindness in diabetic retinopathy, then answer will be retinal detachment. Answer will be retinal detachment if they ask you about the most common cause of blindness in diabetic retinopathy. Then the answer will be retinal detachment. Okay. This much is done. Give me a thumbs up. Shall we move on now? Loss of vision and blindness cannot be never be seen. Loss of vision and blind means there is no light perception. See, next topic, write down. Next topic is CRVO. Next topic, write down CRVO. CRVO is, write down, full form is CRVO, Central Retinal Vein Occlusion. These are the central retinal vessels which are emerging from the optic cup. Now, if there is occlusion in the central retinal vein, you will see hemorrhages in all the four quadrants. Can you appreciate hemorrhages are present in all the four quadrants of the fundus of the retina? Right? So if hemorrhages are present in all the four quadrants of the retina, then the diagnosis is called as central retinal vein occlusion. Then your diagnosis is central retinal vein occlusion. Okay. So how you will make the diagnosis if the image-based question is asked? You have to see which sector of retina is involved in the hemorrhage. If the hemorrhage is present in all of the fundus, then your diagnosis will be central retinal vein occlusion. Okay, your diagnosis will be central retinal vein occlusion. Here, now write down in CRVO, write down central retinal vein occlusion. Cause, write down hypertension. Most common cause of CRVO is hypertension. Hypertension. Now write down types of CRVO. So it is of two types basically. One is non-ischemic and the other one is ischemic. Now, can you tell me which type of CRVO will have poor prognosis? Which is more advanced form? The one in which ischemia has set in, or the one in which there is no ischemia yet? Ischemic one. Correct. So ischemic CRVO is more advanced one and it has poor prognosis as compared to non-ischemic CRVO. Okay. So write down this non-ischemic CRVO. You will see mild hemorrhages. You will see mild hemorrhages in the periphery of the retina. Whereas in ischemic, you will see severe hemorrhages. Severe hemorrhages are seen, giving which appearance? Splashed tomato, or tomato ketchup appearance. Tomato ketchup. Tomato ketchup appearance. Important question. Direct question can be asked, image based. Tomato ketchup appearance seen in ischemic CRVO. Ischemic CRVO. Okay, clear? Now suppose next heading, write down BRVO. BRVO is branched retinal vein occlusion. Branched retinal vein occlusion means these are the vessels. Now suppose only one branch is getting occluded and you see hemorrhages in only one quadrant. Hemorrhages are seen only in one quadrant. Then your diagnosis is BRVO. And the most common sector which is involved in BRVO is your superiotemporal quadrant. Superiotemporal, this one. This is also superiotemporal quadrant. So this is the most common sector which is involved in BRVO. So how you will differentiate between CRVO and BRVO is clear. If in image they will show you fundus picture, which is involving all the four quadrants are filled with hemorrhages, then your diagnosis is CRVO. And if only one sector is involved in hemorrhages, then your diagnosis will be branched retinal vein occlusion. Only a branch is getting occluded. So diagnosis will be BRVO. Clear? This much is clear to you? So this hemorrhage CRVO is called as tomato ketchup appearance or splash tomato appearance. Clear? So this is how we do lasers in the retina. Can you spot the laser marks? Laser marks. So after doing FFA, we locate the point of leakage, and at those leakage point, we fire argon laser, and the process is called as pan-retinal photocoagulation, PRP. Clear? Give me a thumbs up if it is clear. CRVO, BRVO, laser photocoagulation. Give me a thumbs up if it is clear. Will laser mask makes visual field defects? Yes, sometimes they can cause visual field defects. Sometimes, yes. In certain areas, they can give you blind spot. Scotomas can be there. Right. Anything else? Difference one more time. Difference between BRVO and CRVO, right? See, if in the exam, they give you picture like this, can you appreciate what is the problem in this fundus picture? You can appreciate hemorrhages are there, right? So there are four quadrants. This is your superior temporal quadrant. This is inferior quadrant, inferior temporal. This is nasal, superior nasal, and this is inferior nasal, right? So if hemorrhages are present in all four quadrants, okay, then go blindly and tick mark CRVO. CRVO will be the answer. Okay. And if hemorrhage is present only in one quadrant, in this one, rest of the quadrants are clear, no hemorrhage, then answer will be BRVO. Branch retinal vein occlusion. Only a branch of the vessels of retina are getting occluded. That is why there is hemorrhage in only one quadrant. So that is the basic difference between CRVO and BRVO. Clear? Clear, clear? So this is a picture of BRVO. Can you appreciate? Can you appreciate hemorrhages are present only in one quadrant? So this is BRVO. Right? So if someone has asked about treatment, treatment is same. Treatment is same. There is hemorrhages, so we have to do PRP, pan-retinal photocoagulation is done. Okay, so we have to do pan-retinal photocoagulation in CRVO. Clear? So next, write down. Next important topic is your central retinal artery occlusion, CRAO. CRAO is central retinal artery occlusion. Write down the causes of CRAO. Causes of CRAO. Number one cause is hypertension or atherosclerosis. Hypertension or atherosclerosis. Second is carotid artery emboli. And the emboli name you have to remember. It is called as Hollenhorst plaque. This is a cholesterol emboli. Cholesterol emboli. So these two causes, and the third one is giant cell arteritis. Giant cell arteritis. So these are the three causes of CRAO, central retinal artery occlusion. Okay, one more thing in CRAO you have to remember. Let's see. Basically, ophthalmology is a very cool branch. Why they call it as cool branch? Tell me. Have you heard that ophthalmology, they say it is a cool branch, like dermat? So why it is called as cool branch? Don't know. Okay. So it is called as cool branch because there are very few easy to score. Oh no. So no emergency, right? So basically there are no emergencies and you can sleep peacefully. Second point is carotid artery emboli. And the name of the emboli is Hollenhaus plaque, which is the cholesterol emboli. This get blocks in the carotid artery, which can lead to central retinal artery occlusion. So it is called as cool because there are no emergencies. Very few medical emergencies are there in ophthalmology, but CRAO is one of the medical emergency. This is a medical emergency. Okay. Now write down clinical features. Patient will have sudden painless loss of vision. Patient will go to patient, if you see the fundus, patient will have optic atrophy. Patient will have optic atrophy. Which type of optic atrophy? Consecutive type of optic atrophy will be there. If you see the pupil, patient will have RAPD, or also called as Marcus gun pupil. So normally if you throw torchlight on the pupil of a normal patient, the pupil will constrict. Whereas in these RAPD patients or Marcus gun pupil, when you throw the torchlight, pupil, instead of constricting, it dilates, right? So it is RAPD you will see in CRAO patients. Next important finding is that you will see cherry red spot is seen at the macula. Cherry red spot is seen at the macula. So how the cherry red spot looks like? Cherry red spot. See, can you see there is retina is pale relatively. It is not pink in color. So surrounding area is pink, and can you see this hyperpigmented spot is there? This is your cherry red spot. This is a typical finding seen in CRAO patients. Cherry red spot. Cherry red spot is seen. Now you will see cherry red spot in other pathologies also, like in medicine. Okay, so there are very many number of diseases in which you will see cherry red spot apart from CRAO. Mnemonic, write down differential diagnosis of cherry red spot. Write down the mnemonic. Cherry trees never grow tall in sand and garden. C stands for CRAO, central retinal artery occlusion. T for trauma. Which trauma? Blunt trauma, and not the penetrating trauma. N stands for disease. G stands for gangliosidosis. T stands for Tay-Sachs disease. Sandhoff's disease. Sandhoff's disease. And G, Gardner, stands for Gaucher's disease. Gaucher's disease. So these are the differential diagnoses of cherry red spot. Okay. This is a medical emergency and treatment is done within 24 to 48 hours. Treatment is done within 24 to 48 hours from onset of occlusion. Otherwise, it is a irreversible change. The patient will go to ischemia, irreversible ischemia will be there. So coming to treatment, initial treatment, write down CRO. You go for ocular massaging. Ocular massage is done. Why ocular massage is done? Write down to cause changes in blood flow. Second, after massaging, you give vasodilators like sublingual isosorbide nitrate. Second vasodilator we give is carbogen. Important question. Carbogen is 5% carbon dioxide plus it is 95% oxygen. Third, IOP reduction. We can give, because it is an emergency, we can give IV mannitol. IV mannitol is given. How to differentiate CRVO and CRAO? This is very simple. CRVO, what were you seeing in fundus picture in CRVO? You were seeing hemorrhages in all the 4 quadrants. And what are you seeing in fundus picture of CRAO? There are no hemorrhages now in CRAO. In the fundus picture, I have shown you. Can you see any hemorrhages there in CRAO? No. Pale retina is there and you are seeing a center red spot at the macula. So easily you can differentiate cherry red spot and CRVO. In CRVO, the picture was full of hemorrhages, right? Whereas in CRAO, you are seeing no hemorrhages are there, right? There is only pale retina and center cherry red spot. So it's very easy. So this is your treatment of CRAO. Okay, good. Tomato splash appearance in CRVO. Right. Clinical features. Which clinical features? CRAO? CRAO, you patient will have no clinical features will be there. Patient will have sudden painless loss of vision in CRAO. Patient will have sudden painless loss of vision. That's it. Patient says, comes to your OPD, that suddenly he will give you a history of 6 hours, 12 hours, 24 hours, that the patient is having sudden loss of vision in his right eye or left eye, painless. That's it. No other symptom is there. And then when you dilate the patient, examine the fundus with the help of indirect ophthalmoscope, then you will see a cherry red spot and pale retina, which gives you a diagnosis of CRO. Okay. RAPD means when you throw the torchlight on the pupil of that patient with CRO, instead of constricting, pupil should constrict, it will dilate. In RAPD, it will dilate. This means it has relative afferent pupillary defect. Something is wrong with the nerve fibers. Here, other name of RAPD is Marcus gun pupil. Now, next topic we will take on. Next topic we will take on retinopathy of prematurity. Retinopathy of prematurity. Okay. Now try to understand. Prematurity means in premature children's. Premature children's. Right? So, as the name suggests, it is a disorder of the retina. Some retinal pathology is there, which is seen in newborn kids, neonates, infants. Okay. Now, try to understand the pathology only. Don't write and draw anything. This is your optic disc, right? As I told you, this optic disc and this is your macula, suppose. Then I told you that this optic disc and your macula is your central fundus, right? It is your central fundus, and rest is the peripheral fundus, ora serrata, right? Now, what happens when the child is in utero? The vascularization of the retina starts from your optic disc. Vascularization starts from your optic disc first. Clear? This much is clear. Give me a thumbs up. In utero, vascularization starts in the retina from which part? From the around the optic disc. Give me a thumbs up. Yes. So vascularization in utero, when the child is in utero, vascularization starts around the optic disc, around the optic nerve head. Okay. Then from the optic disc, it goes to your nasal half of the retina. After optic disc, which part of retina get vascularized in utero? Nasal retina. And in the last, when the child is 39 to 41 weeks, then your temporal retina gets vascularized, this area. Okay. When the child is 39 to 41 weeks, in the last, your temporal retina gets vascularized. This much is clear. Give me a thumbs up. Give me a thumbs up if it is clear. So vascularization in utero starts around the optic disc, then it reaches your nasal retina, and after nasal retina, in the last, when the child is 39 to 41 weeks, your temporal retina gets vascularized. Okay. Now, what will happen if the child is prematurely born? Premature kids, what will happen? Which part of retina will not be vascularized if the child is delivered prematurely? Tell me in the chat box. Temporal, correct. Because temporal is getting developed, getting vascularized in the last, in premature kids, which part of retina will not be vascularized? Temporal retina. So that will lead to retinopathy of prematurity. Clear? That will lead to prematurity, retinopathy of prematurity. Now write down. Write down. Stages of ROP. ROP is retinopathy of prematurity. First, we will discuss stage 1. Demarcation. You will see a demarcation line between, BW is between, B oblique W, between avascular and vascular retina. Right? Avascular and vascular retina, you will see a demarcation line. In stage 2, this line is converted into a ridge. It is converted into a ridge. Ridge is slightly elevated. Line is straight. Ridge is slightly elevated. In stage 3, you will see extraretinal fibrovascular proliferation. In stage 3, you will see extraretinal fibrovascular proliferation. In stage 4, you will see partial retinal detachment. RD is retinal detachment. RD is retinal detachment. RD is retinal detachment. Stage 5, you will see total retinal detachment. Stage 5, you will see total retinal detachment. Okay. Now write down question number 1. After stages, write down question number 1. ROP occurs in whom? Retinopathy of prematurity occurs in whom? Write down answer. If the age at birth, if the age of the baby at birth is less than 34 weeks, and if the birth weight of the baby, is less than 1750 grams. Okay. Second question. Screening. In whom we should screen? Which patients with baby should be screened for ROP? GA is gestational age. If gestational age of the baby is 28 to 34 weeks, or if the birth weight of the baby is less than 2000 grams, BW is birth weight, then ROP screening is done at 4 weeks after the birth. 4 weeks after birth. If gestational age, GA is gestational age, 28 weeks to 34 weeks, or birth weight is less than 2000 grams, then ROP screening to be done at 4 weeks. Gestational age of the baby is less than 28 weeks, or if the birth weight of the baby is less than 1200 grams, then ROP screening is to be done at 3 weeks after the birth. 3 weeks after the birth. Coming to treatment, again, we give and we do laser photocoagulation. Laser. So the timing of screening and ROP occurs in whom? These things you have to remember. Important. Now write down next. cystoid macular edema. Cystoid macular edema. Write down the risk factors of cystoid macular edema. What are the causes or risk factors of cystoid macular edema? So there are a number of causes for cystoid macular edema. Write down the mnemonic. Mnemonic for cystoid macular edema, write down run for pride. Run for pride is the mnemonic. Stages, they can directly ask, what is the stage 3, what you see in fibrovascular proliferation? What is the stage of stage 4, partial RD, right? So run for pride, there R stands for, this factors R stands for retinitis pigmentosa. U stands for uveitis. N stands for niacin or nicotinic acid. P stands for PG analogs. R stands for retinal vein occlusion, and which CRVO and BRVO. Or Irwin gas, which is a cataract. It is rarely seen, rare complication. Not D stands for diabetic retinopathy, and E epinephrine in aphakia. Aphakia means without lens. Absent lens is aphakia. So these are the risk factors for cystoid macular edema. Talking about treatment of cystoid macular edema, we give steroids, we give anti-VEGF injections. Okay, steroids and anti-VEGF injections are given. VEGF injections are given. CSR. CSR is central serous retinopathy. Central serous retinopathy. Now let us understand the concept. Break I'll take after 30 minutes, 5 o'clock. Let us first understand the concept behind CSR. Let us see the picture of CSR first. See, can you see a ring is there at the fundus? This ring, can you appreciate? Give me a thumbs up if you can appreciate this ring at the fungus, at the fundus. This is not normal. This is not normal. It is showing that some edema is there. Macula is having some edema. Now, what will happen in CSR? Go back to the anatomy of the layers of the retina, right? So we have discussed that there are 10 layers of retina, and this is the outermost one was RPE, okay? And these were the 9 layers of the retina, rest of the 9 layers. No, this is not optic disc. Okay, so these are the 9 layers, and these are the 9 layers of retina, and this is your RPE, right? These 9 layers of retina are called as 9 layers of retina apart from RPE are called as, what is the name? Right, neurosensory retina. Good. Then we discussed that between neurosensory retina and RPE, there is a potential space. That space was called as, that potential space was called as subretinal space. That potential space between RPE and the rest of the 9 layers was subretinal space. Okay. Now, what happens in CSR? Which layer is present beneath this RPE? Beneath the retina, which layer is present? In the OCT also, if you see, this is suppose RPE. Which is this layer? Beneath the RPE, beneath the retina, what is present? Which layer is present? Choroid, right? So this is choroid, right? So what happens due to this choroid contains choriocapillaries. Choroid contains choriocapillaries. Choroid contains your choriocapillaries. Now what happens in CSR is there is leakage from the choriocapillaries. There is leakage of fluid from the choriocapillaries. Okay. Now what will happen if there is leakage from the choriocapillaries? This is choriocapillaries. So there is leakage from the choriocapillaries. So this leaked fluid will pass through the RPE, through the fenestrations in the RPE, and this fluid will accumulate in the subretinal space. Okay. And the rest of the 9 layers, the neurosensory retina, is elevated. Right? This much is clear. Give me a thumbs up if it is clear. Give me a thumbs up if it is clear. There is leakage of choriocapillaries in the choroid. Leak fluid through the fenestrations in RPE gets collected in the subretinal space. And this subretinal space gets elevated, and the rest of the 9 layers get elevated also. Clear? So if this, yeah, good. So if this accumulation of fluid is located in the subretinal space at the macula only, then that condition is called as CSR. Yes, this is also a kind of edema, right? But the layers are different. The edema is located in the subretinal space only. Okay. So which investigations we will go? First we do retina examination. Then we go for OCT. And then after OCT, we have to see what is the site of leakage. For that, we have to go for FFA. Clear? So OCT and FFA both are to be done. Now write down in CSR, write down. Central CS retinopathy, write down risk factors. Risk factors you will correlate with yourself also. More commonly seen in males between 25 to 55 years of age. More commonly seen in type A personality. Type A means hyperactive personalities. Seen in pregnancy also. Pregnancy. Stress is one of the major factor. And smoking. Smoking also. Okay. Now coming to management. MX is management. CSR is confirmed by which two investigations? OCT and FFA. Okay. Now on, you will see two findings will be there. The name of first finding is smoke stack appearance. smokestack appearance, and second is ink appearance. This ink blot appearance is most common presentation. Ink blot appearance is most common presentation on FFA in CSR. Now coming back to the picture is also important of the FFA. Can you see this picture? And this leakage is example of ink blot appearance seen in CSR. This picture and this question can directly be asked as image-based question also. So you have to identify the FFA picture. The diagnosis is CSR. This is ink blot appearance, most commonly seen. Clear? Now coming back to the no treatment is required generally. Only observation, as most cases they resolve spontaneously. If you counsel the patient, then mostly the cases resolve spontaneously. Important question. Observation. So usually no treatment is required. Okay. So this is all about your CSR. Next, write down. Next topic is retinitis pigmentosa. Retinitis pigmentosa. I'll show the picture first. See, this is the picture. Can you see the abnormality? Can you appreciate what are the abnormalities in this fundus? See, one thing is that the color of the optic disc is not pale pink in color. It is somewhat pale disc is there, right? Then second thing, can you focus on the vessels? Are the vessels normal? No, they are attenuated. Vessels are thinned out, right? So these vessels are attenuated. And third finding, can you see these black spots are there, blackish? So these blackish things are called as bony spicule pigmentation. Bony spicule pigmentation. Okay, bony spicule pigmentation. So now write down, this is a typical picture, can be asked as direct image-based question also. So triad of three things: waxipellar optic disc, arteriolar attenuation, and bony spicule pigmentation is seen in retinitis pigmentosa. Now write down RP, retinitis pigmentosa, write down. What are the findings? This RP, short form I'll write RP, retinitis pigmentosa. This is the most common hereditary fundus dystrophy. Okay. Now this predominantly affects rod cells. Predominantly affect rod cells. Now you will tell me, what is the location of rod cells? Where is the rod cells more commonly located? In the central retina or in the periphery of the retina? Tell me in the chat box. Periphery of the retina, right? Good. Now you will tell me, in the retinitis pigmentosa, I have told you that it affects predominantly rod cells. So if rod cells are affected, which type of loss of vision will be there in retinitis pigmentosa? Which type of loss of vision? Central loss of vision or peripheral loss of vision? Chat box, write down. Which type of loss of vision will be there if rods are gone? peripheral loss of vision will be there, right? And these rods are responsible for black and white vision. Rods are responsible for black and white vision, whereas cones are responsible for central vision and your color vision. So your black and white vision will also be lost. That is why patient will complain to you with night vision loss. That is called as nyctalopia, right? So write down, it predominantly affects rod cells. Write down symptoms. Patient complains of nyctalopia. And this is the earliest feature. Earliest feature is nyctalopia. Then there is loss of peripheral vision. Now, suppose this is your retina and there is loss of peripheral vision. This is the loss of peripheral vision. Now, gradually your periphery is going because of progression of retinitis pigmentosa, right? Now, what will happen? Only the central vision will remain. Okay, only your central vision remains. The periphery is gone. Now, what is the type of visual field defect it is? Write down. Visual field defect. In retinitis pigmentosa, you will get a ring. This is a ring, yeah. So this looks like a ring. Ring scotoma, also called as donut scotoma, because it resembles shape of donut. That is why it is also called as donut scotoma. Important question. Donut scotoma is seen in retinitis pigmentosa. And this donut scotoma, only central vision remains. Central vision, tubular vision, as if the patient is looking through a tube or tunnel. So that is why it is called as tunnel vision or tubular vision. Important question. Tubular vision or tunnel vision is seen in retinitis pigmentosa. This message is clear. Give me a thumbs up if it is clear. Donut scotoma is clear? Yes. Only the central vision will be there. Periphery is gone. Now write down signs. Signs we have already discussed. It has a triad of arteriolar attenuation, thinning of vessel is there. Then pale, waxy. So pale, waxy optic disc is seen. And bony spicule pigmentation is seen. These are the three signs which are characteristic of retinitis. Clear? Now last topic is write down retinal detachment. Retinal detachment, write down. So first try to understand the tunnel image once again. Tunnel image means the periphery is gone. So right, only the central vision will remain. So it will be like as if patient is seeing through a tunnel. So that is why it is called as tunnel vision, right? In chronic stage, LOV, there will be loss of vision in chronic stage. Yes. It is a hereditary disorder, so no treatment is also there. So gradually the patient will have loss of vision. Patient will not be able to see the periphery, only the central vision will be there. So coming to retinal detachment, we have discussed the pathology of CSR, which is quite similar to retinal detachment. See, in CSR, what was happening? The choriocapillaries were leaking beneath the RPE, and the fluid was accumulating in the subretinal space, right? And the neurosensory retina, the 9 layers were separating, elevated, right? Now, if this process is limited to only macula, then it is called as CSR. But if this process is present in all over the retina, then that is called as retinal detachment. If the separation of 9 layers is occurring all over the retina, then it is called as retinal detachment. If the separation of the 9 layers of the retina, neurosensory retina, is limited to macula only, then that is called as CSR. Okay. Now write down retinal detachment. Write down retinal detachment. Types of retinal detachment. Write down types of retinal detachment. It is of 3 types. Rhegmatogenous retinal detachment, tractional retinal detachment, and exudative retinal detachment. Exudative retinal detachment. Now coming to important causes of these 3 RDs. Causes you have to remember. First is pathological myopia. Pathological myopia. What is pathological myopia? Write down. If the axial length of the patient is more than 26 millimeter, if the axial length is more than 26 millimeter and power of the patient is more than -6 diopters, then it is called as pathological myopia. Myopia, clear? So if the axial length of the patient is more than 26 and the power of the glasses is more than -6, then it is called as pathological myopia. So these pathological myopia patients, they are prone to develop a rhegmatogenous retinal detachment. Okay. Next cause, write down aphakia. Aphakia is absence of normal crystalline lens. Third cause is blunt trauma. Blunt trauma. Now coming to tractional RD. The most common cause of tractional RD is proliferative diabetic retinopathy, PDR. Second cause is also P, which is penetrating ocular trauma, which we have studied in sympathetic ophthalmitis. And third also is P, which is retinopathy of prematurity. Remember stages 4 and stage 5 of ROP, partial RD and total RD. So which type of RD was there in ROP? Tractional retinal detachment was there. So 3 Ps are there: PDR, penetrating ocular trauma, and ROP. Exudative RD, write down causes. Important one is choroidal. Second is toxemia of pregnancy. Third, CSR, central serous retinopathy, CSR. So these are the 3 important types of RDs and causes you have to remember. Okay. Next, Before taking a break, write down important topic. Last is retinoblastoma. So we have studied retinoblastoma before. Now tell me, what was the treatment? What was the treatment for retinoblastoma? Which surgery we have discussed in retinoblastoma? Enucleation, right? And evisceration was for endophthalmitis, right? What is the most common cause of late onset endophthalmitis? Very important question. Most common cause of late onset endophthalmitis. Name of the starts also with P. P. acnes, right? Good. P. acnes, Propionibacterium acnes. Propionibacterium acnes. Write down in retinoblastoma. This is the most common primary intraocular malignancy in childhood. Inheritance is autosomal dominant. Important question. Important question number 2, write down. Most common primary tumor associated with retinoblastoma. RB is retinoblastoma. So most common primary tumor associated with retinoblastoma, answer is pinealoblastoma. Question number 3, write down. Most common secondary malignant associated with retinoblastoma, osteosarcoma. Coming to coma, patient presents to you with leukocoria reflex. Other name for leukocoria we have discussed in endophthalmitis. It is also called as hemorrhagic cat eye reflex. If you remember, yesterday we have discussed it. And this leukocoria is most common clinical feature. Important question. Most common clinical feature. Most common clinical feature. Second important clinical feature, write down. Patient will have squint. Esotropia. Now try to understand this esotropia. Suppose I am looking straight, right? So what will happen in esotropia? Eso means my eye, suppose my right eye is having esotropia. What will happen? It will be deviated towards my nose, right? If my eye is deviated towards my nose like this, then the squint is called as esotropia. Okay. If my eye is deviated away from my nose, outside, that is called as exotropia. Clear? So exotropia, esotropia. Eso is towards my nose, right? Give me a thumbs up if it is clear. Esotropia, exotropia. Okay. So patient will have leukocoria, patient will have esotropia, patient will have secondary glaucoma with Ophthalmos. Important question, write down. The most common route of spread, which we have discussed this line before. Most common route of spread is through optic nerve. Coming to treatment. Treatment of choice we have already discussed. Enucleation. So there is removal of whole eyeball along with optic nerve. Okay, enucleation is done. Now we have discussed leukocoria in endophthalmitis, and we have discussed leukocoria in retinoblastoma. Now write down leukocoria, differential diagnosis of leukocoria, very important. So the mnemonic for differential diagnosis, write down. Mnemonic, write down. Please take extra. Please take extra 3 RC, 3 into RC. CAMS stands for PHPV. It is primary hyperplastic primary vitreous. T stands for psoriasis. Endophthalmitis. Now there are 3 R and 3 C's. 1 R is retinal detachment, RD. Second of prematurity, and third is retinoblastoma. 3 C's. C, Coats disease, cyclitic membrane, coloboma, and CANS, C stands for central cataract, like mature senile cataract, because it is pearly white in color. So these are the differential diagnosis of leukocoria. Please take extra 3 RC CANS. So we'll take a 10 minutes break and we'll come back again. Okay? 10 minutes